afternoon, everyone. Welcome back to the last session of the day. Hope you've enjoyed the conference and you've had a chance to visit the resource center. So my name is Lorraine Chipira and I'll be facilitating this session this afternoon. So in this session, I'm really looking forward to the discussions where people will be talking about how they have the big examples of how people have developed and action strategies to tackle health inequalities, working in collaboration with various stakeholders and at multiple levels. So you hear some examples of place level, system level, and regional level as well. And for the audience, we'll be answering as many of your questions as possible at the end of the presentations. So please do keep submitting your questions in the box to the right of the video screen. So before we start, I'll let the panelists introduce themselves, starting with Emma.
Good afternoon, everyone. I'm Emma Latimer and I'm the Executive Place Director for Sheffield as part of NHS South Yorkshire Integrated Care Board. Great to meet you all virtually.
Thank you, Emma. Justin?
Hi, I'm Dr. Justin Money. I'm Director of Public Health for Birmingham City Council and a member of the Birmingham Solihull ICS Board and ICS Partnership.
Yeah, thank you, Justin. Anya?
Hi, everyone. Nice to meet you. My name is Dr. Oni Okonkwo. I'm one of the non-executive directors for Birmingham and Solihull ICB, but I'm also transitioning out as the chair of BLECHEC, which is a task force looking at health inequalities in the African and Caribbean communities.
Thank you, Anya. Mike?
Good afternoon, colleagues. I'm Mike Wade. I'm the Regional Director of Public Health for the Midlands, so that's East and West, and my role is a joint appointment between the Office of Health Improvement and Disparities and NHS England Midlands.
Thank you. And lastly, Stephen.
Good afternoon, everyone. I am Stephen Raybould. I am Programmes Director at Birmingham Voluntary Service Council, and I am also Chair of the BSOL VCSE Leadership Alliance.
Thank you very much. Thank you all for coming. So before going to our presentations, each presenter will have 8 minutes to speak. And afterwards, we then have the Q&A, as I said before. So our first speaker, Emma, welcome.
Thank you. There we go. Okay, thank you. Can everyone see the slides? Great. Okay, thank you. Okay, so with my 8 minutes, so as I said earlier, so I'm Emma Latimer. I'm the Place Director for Sheffield, and as part of the ICB arrangements, we have a delegated budget in Sheffield of £1.4 billion, with the 10th biggest city in the UK, and we have obviously lots of issues around deprivation. So when I started in the ICB, we wanted to talk about health inequality in a slightly different way. So rather than trying to spend the health allocation across the whole of Sheffield, we decided that we'd look at creating what I'm calling a model neighbourhood in the northeast of Sheffield. So the northeast of Sheffield is our most deprived area, and we've got some significant issues around BAME populations. We've got sort of racial issues around infrastructure and lots of issues relating to different populations. So rather than spread our resource quite thinly, we decided to look at those 4 areas. So our ambition is to empower communities in the northeast of Sheffield to live happier and healthier lives. And what we're doing is actually giving money to 4 community anchors in those 4 areas. So looking to connect people to each other in their communities through increased investment to local VCS organisations, to build community capacity of individuals and neighbourhoods to help them address issues that are important to them. So rather than saying, we want you to stop smoking, we want you to do this, or some of the more traditional public health initiatives that we've tried in the past, we're looking to devolve power to communities for them really to start to commission things that truly matter to them. Obviously, the NHS can't act alone, but using some of the ICB resource in terms of how we start to frame the way we do things and actually to put some long-term resource in there as well. So we've got a 5-year plan for the North East model neighbourhood in Sheffield. We started with about 800,000. I've actually been able to double that this year to 1.6 million, which probably doesn't feel like a great deal. But in terms of ensuring we have that recurrent investment, it's not just a one-off, and we start to build on that. So it sets out a new way of creating health and well-being and connecting with our communities. And it builds on the Health and Care Partnership. And the Health and Care Partnership is the body that I chair that has all providers, the voluntary sector, the local authority, Health Watch, and key members of our community on it, to strengthen connections, to build that community capacity and to address these issues. So obviously we know that communities have the knowledge, skills and assets, which mean they are best placed to identify and respond to challenges. And we want local people to know their neighbours, look out for each other and have a thriving community. And I think it's probably the role of place and integrated care boards to create those conditions to enable people to thrive, but in a very different way. So there's lots of evidence that points to successful, sustainable change happening at grassroots level. And our job really is to facilitate that. So the idea is that we change Sheffield one neighbourhood at a time, but starting in this very, very deprived area across 4 different patches. So the locality approach that we're taking is, again, it's devolving power. I've already talked about that. Making sure we prioritise relationships. So we're looking very much at a non-medical model based on relationships and connections, not services. So again, when people talk about neighbourhood models, often that's around primary care networks and involves medical team members. This is very much around communities themselves and what they can do to become more resilient. Again, not just those areas. We're looking at recognising communities of interest alongside the neighbourhood. So we're doing some particularly targeted work with some of our most diverse communities as well to try and readdress the balance in funding for Black, minority and ethnic communities. And again, we're looking at the community plans being led by those communities, not system-led at all, focusing on what's strong and local and not what's wrong. So in terms of where we are in our journey, true partnership working, as I say, we've got a huge number of partners involved in this in terms of the public sector reform work. So voluntary sector, the NHS, the City Council, the police, the DWP, primary care networks. And we've also got New Local, who are an independent think tank nationally. They're working with us to co-produce the programme plan and to evaluate this programme. Because again, what we're looking to do is really try and influence policy. We want this not to be some sort of pilot, but to actually start to change the way we protect prevention, investment in the NHS. As I said earlier, we can't act alone, but we need to work alongside others. But this can't just be a one-off 12-month pilot. We need to be thinking about, you know, what's going to stick in the next 5-10 years. And sometimes that's really difficult when you've got loads of problems and issues around access to healthcare. Trying to carve out resource for this particular area has been difficult, but we've managed to do it. So we've got this programme, we've set the programme up, we've done some sense making, we've involved the VCSE in investment and development, we've done some community engagement. So we're at that stage where you see the star. We're now looking at finalising the community plans and embedding that system change plan. So we've put the investment in, we've partnered with an evaluation partner, we're issuing micro and small grants, and we're looking to invest in the leadership. So this isn't just about filling a void in the VCSE sector. This is about growing capability and capacity in those leaders, those change agents, to be able to deliver this long-term change moving forward. So as I said before, we've got 4 community organisations. They are at different stages as community anchors, and we are working alongside them to scale up community development approaches in the North East, scaling up operational services. There's a huge plethora of different initiatives, and we're also looking at community researchers who are part of this, who really act as our eyes and ears in those spaces and can help us administer some of those small grants in terms of that year 1 sustainability investment. So that's really just a kind of whistle-top story of what we're doing. But what I would say is, I think I'm on 9 minutes, you know, it is a very different approach. It's about really shifting power away from NHS commissioning into communities and supporting and enabling and creating conditions for them to thrive in a long-term environment. So I'll stop there because I think I'm just slightly over time probably. Thank you.
Thank you, Emma. Really interesting points. Hopefully, we get some time later to talk about, like you said, about the challenges and balancing priorities and how you devolve power. So thank you very much. We'll hand over to Justin. Thank you.
Great, thank you. I'll just get the presentation up and running. As a colleague was saying earlier, we've all got used to Teams, so working in Zoom is a different space for us, but great. Hopefully everyone can see that now. So I'm just going to talk about this from a kind of strategic level approach and some of the learning I think we've had on journey in Birmingham Solihull. For those of you that are not familiar with Birmingham, England's second city, population about 1.14 million across Birmingham. Across the whole of our Birmingham Solihull system, we're about 1.3 million as an ICS. So we also have that interesting dynamic of Birmingham being 5/6 of the overall place that our ICS covers, and a globally diverse city with the first unitary authority to move to a white British minority, and really you can eat your way around the world in terms of Birmingham, as well as see it in many of our green spaces and environments in which we live. We also sadly have large proportions of our population living in deprivation, and that's a real challenge for us as a system when we come to responding to the health inequalities we face. And this diagram just gives you a sense of this. For those of you who haven't had the pleasure of travelling through New Street on your way from London to the north, these are the train stations across the city, and you see the deprivation maps onto them in the life expectancy. Within Birmingham, we have about a 10-year life expectancy gap between boys born in the most deprived areas and boys born in the most affluent areas. Slightly smaller gap for girls, but a significant amount of inequalities to unpick. And when we think about inequalities in this space, we talk about communities in different ways. And I think one of the limitations we've often had in the past is we've talked about communities defined by their geography, and not really considered them in the context of their identity or their experience. So in Birmingham and Solihull, we talk about communities of place. Those are geographically defined. We talk about communities of identity, and most of us would kind of go to the protected characteristics, people's gender, ethnicity, their sexual orientation, those things they look in the mirror and go, I am. And then we talk about communities of experience, and that might be life experiences for, say, some of the inclusion health groups like veterans or care leavers, but it also would be communities of experience defined by a disease condition as well. So people who've experienced stroke would be classified as a community of experience. And that's helped us when we thought about inequalities in slightly different ways, and when we're kind of responding to them, looking at them through a different set of prisms. And when we talk about health inequalities, it is important to kind of have a shared vision of what are we trying to get to. You know, for a long period, we've talked about equity. Well, first of all, we start about equality, and this American graphic demonstrates it well. Give everyone the same box and forget that people are different heights and therefore they can't see over the fence. Then we move to equity, which is give some people more boxes so they can see over the fence. Now I think as a system across the country, we're starting to think more about, can we replace a wood fence with a chainmail fence? And that gives everyone the ability to see through the fence. But where we really want to get through is to a level of agency where we don't have fences and that people can participate fully in the game and be full active members of a civic society, where we don't need to think about a fence to create a barrier between those playing and those observing. And again, that's been an important part of our journey on inequalities, to really talk about what are we trying to do and the tools and the approaches that we take to change that. When we talk about the data role, and I think it is important we talk about the data role in this, there are lots of sources for data. And lots of places that we can go to look. And as we've been on this journey as a system, we've really started to unpack and understand the limitations to that data. In a city that's globally diverse as Birmingham is, it is not acceptable just to talk about Black people. We have a large enough Somali community, Nigerian community, and Ghanaian community, let alone our Jamaican and non-Jamaican Caribbean communities. They don't all agree, they don't all have the same health inequalities, and yet we homogenize them in this shorthand, which is just not acceptable. And some of that is driven by the way that we collect our data as well. So having a really open conversation, both with communities and within our system, has been key to this. So a couple of kind of pillars that demonstrate how we've moved from that kind of intelligence to action. So first of all, about having a strategy and a policy which all joins up together. So we have 2 health and wellbeing boards in the 2 main places, 2 local authorities, that joint together in a 10-year strategy across the ICS, which I led on behalf of the ICS. And you can see a direct read through from the 2 health and wellbeing board strategies into the metrics of success. But we've also really focused on this thought of subsidiarity, do the right thing at the right level. Sometimes it is not the right level to do things at an ICS footprint. Sometimes it's not the right level to do them at health and wellbeing footprint. We've got to get more granular. So really having that open conversation each time, why are we doing it at what level, and what level makes sense for the outcome we're trying to achieve. Secondly, having visible and consistent leadership, really understanding that if we're going to change the burden of health in society, we need to look not just at clinical care, but we also need to look at health behaviours, socioeconomic factors, the physical environment, and that different partners are better placed than the ICS at time to lead these. And how do we share that out and talk to each other in a way which is really modelling disseminated leadership? And how can we bring in partners from our community and voluntary sector alongside those from different aspects of the health service and the social care local government structures to collaborate in this space? The third element is around meaningful lived experience, and I know Oni will talk a bit more about this, but we've really been on a journey over the last 5 years in Birmingham particularly to focus on how can we embed citizen voice. And this isn't just having the kind of health watch voice. We're going out, we're commissioning focus groups, we're commissioning community deep engagement partners to help us have a continued and meaningful dialogue with communities to understand their lived experience, to help co-design and co-create solutions, and to really recognise and reflect and celebrate the diversity of our communities, and trying to move away from, at the moment we still are in a deficit-based language because that opens up funding streams, into how do we get to an asset-based language. And one of the key elements of this was the Black Ear Report, a 2-year programme of collaboration which brought together academics, community members from our African and Caribbean communities to not just reflect on, isn't it terrible, these are inequalities, but to reflect on how are we going to change it. For over a decade, we've known that Black women are more likely to die and have adverse maternal outcomes, yet we haven't changed it. And actually having a really honest conversation about why is all this one-stop EDI training not working when it comes to cultural competency is taking us to a different set of conversations about how to make a difference. The next one is around having that open collaboration and challenge. It's a brave space to get into as a senior leader in the system, to sit in a room with people and say, tell me why this isn't working. Having the open conversation. And I think it's something as leaders in this space, we all have to think about. How do you get comfortable with being uncomfortable? Often I've been in spaces where I'm the first time a senior official has sat down with a community for over a decade and they're angry and they've got a lot of baggage that they want to work through and want to tell me about. But at the end of the day, we're both there to try and improve the outcomes for our citizens and for our patients. But actually getting into that space needs to be much more intentional and much more visible. And there are some good ways we've done that working with partners like Brig, but also bringing in independent chairs and really thinking about how we get multi-organizational membership on the keyboards that drive change. The last couple of thoughts I want to share on this. One, and Amy may pick this up as well, and Stephen, because it's a phrase I use a lot in the local system, is that my job is to try and time the skimming of the pebbles into the pond to create a wave that interacts and changes the shoreline. Most of what we do is about small incremental changes that when you join them together in the right environment, create a wave, and that wave shifts the shore. It's very hard to do seismic change through a single action. And actually as a system, really understanding that concept of how we're throwing pebbles into a pond and creating ripples that create waves that then shift a shoreline is fundamental to having a strategy that is truly going to change inequalities rather than having non-recurrent projects that come and go and we're back where we started to begin with. And my final thing I want to share is we've also been creative about this. Too often we take a white British middle class approach, and I say that as a man that comes from privilege, when we're talking to communities, engaging communities. One of the most powerful things we did in the Blackyer report, which is a brilliant report, but it is a technical report in many ways, was we commissioned the Poet Laureate for Birmingham, Casey Bailey, to turn it into a poem. And I wanted to share some of those words with you now, because I think they are really, really powerful, and they resonate with why it is so important that when we talk about inequalities, we talk to our communities and we talk with them. And he said, this review so packed but so important that you read to understand that this system has not taken notice of our needs. Please, we are flowers, do not treat us like we're weeds. We are human. If you cut us, then like you, we will surely bleed. And they've been cutting, ignoring how some ended up on top. The poem goes on, and I really commend to you to hear it and read it in your own time. But it's an important example of how we think differently about how we engage communities in co-creating solutions to what are enduring inequalities in our system. And I hope that's been useful to share with you today.
Fantastic. Thank you, Justin. Really important points you've raised. I think a couple of points that I thought are really quite important around your communities, the different communities of place, identity, and experience. Just made me think around intersections and how in practice, how that might look like. That's really fantastic. And the poem around We Are Flowers, Why Do You Treat Us Like Weeds? I think just embodies some of what we just started talking about capacity, strengths-based approaches and things like that. So hopefully we'll get a chance to explore that a bit more. Fantastic, thank you. So I'll just hand over to Anya now. Thanks, Anya.
Hi, everyone. So I am going to share my screen, and hopefully this works. Right, so picking up from where Justin stopped, I'm going to talk to, okay, thank you. So I'm going to talk to you about BLECHEC, which is one of the specific projects that we've done to try and tackle health inequalities in Birmingham and Solihull. And BLECHEC stands for Birmingham Lewisham African Caribbean Health Inequalities Review. So our job as the task force for the ICS was to actually implement the review that Justin and team had done. So I'm going to talk to you about what we've done as the system in response to this. The wonderful thing about BLECHEC is the fact that for a long time, people keep saying to tackle health inequalities within communities, we don't have data. But this particular review took time to do both a qualitative, quantitative review to actually give us that data that we need. And I'm sure you're asking why African Caribbean? Like Justin was saying, sometimes it's good to talk about these inequalities in like identities, like us as African and Caribbean people. If you listen to what he said about the poem, why is it? What's going on? Why are we not doing anything about it? And in Birmingham and Solihull, we've got 11.5% of our 1.3 million who identify as African and Caribbean. So having this particular review and having to implement the recommendation, although we call them recommendations, we look at them in the ICS as opportunities for action. It has really been life-changing and actually groundbreaking for us to be able to implement it. So this BLECHEC review was launched in June 2022, and we, as an ICS, established the task force in September of 2022. And to make sure that we implement it, our governance is in such a way that through the implementation board, we report to the Health and Wellbeing Board on the City Council side, and through People Power Health Inequalities Committee, we report to our ICB board. So to make sure that we are actually committed as a system to delivering those opportunities for action. So the first thing that we did as a system once we launched the ICS task force was to look at the recommendation, the opportunities that they had made, and we mapped it and we themed it, and we talked to our providers about how they could. First of all, we started with, what are you doing already? Because a lot of times we in the NHS, we do a lot of things, but we don't even sometimes have the time to stop and take stock of what we are doing. And just mapping and theming it, quite a few of the providers were able to see that they were actually doing the same thing. And we now started connecting the dots and connecting the system together to start looking at how we work together and become more efficient. As soon as we got every provider to map and theme what they are doing. We then asked each of them to come up with SMART objectives. I'm going to talk about that later on in a minute. And in addition to the providers, we also have our local organizations. We have Health Watch coming in, because we became almost like a melting point for the system, for everybody to now come and look at how we do this together. And for us to be able to embed it into the system, we've had to align the priorities that we're working through to make sure that it aligns both locally with our strategies and nationally with the NHS strategies and the Core 20+5. So working on it, we've developed it into 4 streams. And these are the streams, and I will talk to us a bit more in detail about them. So the first stream is the providers with their SMART projects. Like I said, they first of all had to come and talk to us about what they were already doing in response. But in addition to that, we've now made each and every one of them come up with at least 2 or 3 SMART objectives to work on in the next 1 or 2 years for the program. And why I've highlighted the last 4 is because each of those SMART objectives had to go through the community partners. So we had 3 community partners, 1 for African communities, 1 for Caribbean communities, and 1 for children and young people, and of course Health Watch. So each of their objectives were sent to all the community partners to answer the most important question, which is the so what. Because we tend to commission a lot of things, but we sometimes forget to see how it feels for the communities that are actually using those services or looking at those objectives. So the community partners were able to mark those objectives for us and tell us how it feels and where they felt something needed to be changed. The providers were able to change it. And at the moment, the providers are still going through those SMART objectives. And each quarter, they come and tell us what is their plan and how they are progressing. And there are so many different objectives that they are working on, ranging from maternity link workers, which I'll talk about in a minute, to trying to make sure that they have the data to be able to implement changes for African and Caribbean communities. And then the next one we looked at was improvement pathways. So we have a lot of pathways, like I said, that sometimes are not culturally sensitive. So we've looked at some of the pathways that we have within our system to see how we can look at it from an African and Caribbean lens and improve it. And one of the most important ones we looked at was the CVD, cardiovascular disease, and increasing hypertension awareness, because we know that the risk of stroke and heart attacks is quite high in African and Caribbean communities. We already had the Birmingham VCSE Healthy Hearts website, but we wanted to put our imprint on it. So we co-produced a script and video content on hypertension with the community partners. They helped to translate it into 4 of the main languages that are spoken in Birmingham and Solihull, which everyone who wants to have access can point a QR code and be able to be taken there, and they can hear it in their own language. And then we trained community champions, what we call community ambassadors, on how to do blood pressure. And when they do the blood pressure, they feed in through the normal pharmacy system. And that way, now, if we have any community engagement events, we the NHS don't go doing the blood pressures. The community ambassadors actually do it for us, which is actually quite revolutionary, because now they are taking control of their own health. And since we started it in November, we've done 720 patients. And out of that, 244 have already been referred to their GPs. And that means at least we're trying to prevent 244 strokes. The next pathway that we looked at was infant mortality and the maternity, local maternity and neonatal service, because we know that we have a high proportion of infant mortality and Black women don't do well, and infant mortality within the African and Caribbean patients. So we started off with listening to the communities. We started with listening exercises facilitated by Health Watch and the providers, the community engagement partners. And after listening to the women, we've now moved on to bi-directional conversations where the local maternity service and the infant mortality team are now empowering the communities to look after themselves. But the most important thing that we've also done is to get all the GPs to register on the bump and Badgernet, so that the patients, when they're pregnant, they bypass the GPs, they get registered straight onto the system. We now have a local maternity link support worker who picks them up at the other end and follows them through their journey, because one of the things that they heard from the women was that they needed advocacy, which is so important for women that English is not their first language. And that way, these women are able to start things like folic acid and vitamin D as soon as possible to make sure that they are cared for and their care is not missed at any point in time. Then the third pathway that we looked at was prostate cancer for men, because one of the PCNs within our system approached us on how they could increase awareness of prostate cancer screening within Black men. And talking to our community engagement partners, the first thing they said was, this isn't going to work if you're going to ask them to come and do prostate cancer screening. So we now turned it to a health and well-being event, of which we ran the first one in February, where the men came out to play football, and we used that opportunity as well to talk to them about prostate cancer screening. We're currently in conversation with ManVan to see if they could come in, so that when we do these health and well-being events, we can do the prostate cancer screening at the same time. Okay, the other work stream is our community engagement events. What we found in April of last year was that the communities wanted us to take health out of the communities out of our surgery into the community. So what we've done is we've started community engagement events. Our first one was with the cancer team, and you can see some of the responses from the communities. They say 100% they wanted us to do that. And since then, we've done about 10 of these. We're either supporting them, or we go to the community, we ask them what kind of people they want to see from the NHS. And then based on their response, we then put the team together to go into that community and be able to do community events with them. So it ranges from checking blood pressure to talking to them about their health, talking to them about prostate cancer, ovarian cancer. And this now is being picked up by BEMA, by the PCNs, by different organizations within the system, but we're still supporting them to do that. And this is an example of one of those. And the last work stream that we have is the co-production with the City Council, because what we found is that across the city, there is that everybody's doing cultural intelligence or cultural competency training, but we didn't have a standard across the system. So we decided to co-produce something with our community engagement partners to look at what do they think as NHS staff that we should know in terms of cultural intelligence and cultural humility and safety. So we're currently piloting this at the moment. So cultural intelligence is for those that are policymakers, to make sure that they understand the system they work in, and then cultural humility and safety is for the frontline workers. And at the moment, like I said, we're piloting them. So what are we learning? I think the first thing we need to understand when it comes to ethnic health is that you need to understand the root cause analysis, and you need data. And when you have that data, you need to have your stakeholders around the table. And whatever you're doing, make sure you're co-producing it with the patients themselves, because you really need to answer that so what question. Creating for them doesn't actually make any sense if it doesn't answer the so what question. And be creative, be courageous, because when we started this program, we didn't have any money, but we decided that we were going to run this. We were going to make sure that this succeeds. And now we're beginning to show our results. Now people are wanting to invest with us, they want to work with us, and they want to see this succeed. And at the moment, what we're doing now is to move into monitoring and trying to embed it into business as usual. So it's been an interesting journey, but it has been absolutely worth it, because it's been created with the community, for the community, and they now own it. Thank you very much.
Thank you, Anya. Really amazing work. And thank you for showing us working with communities, co-production at different levels in practice. I think some of the points that I was looking at, I like when you talked about creative thinking and courage and how important it is to think creatively. I think all along I've been hearing, even from this morning, about working differently, thinking differently around tackling health inequalities and working with communities. So fantastic. Thank you so much. And hopefully we can pick up that later. So just then go on to Mike. Thank you.
Great. Great, thank you. The challenge of coming towards the end of a panel presentation like today is that I'm following excellent presentations, and that our colleagues have done all the hard work and actually made the really important points. So I'll give you my regional perspective, and at best probably reinforce a number of points that have already been made today. But I wanted to start by noting what I think an important challenge is for regions, and that is that we're operating in the absence of a national, cross-party, cross-departmental health inequality strategy to guide the sustainable long-term changes that we're looking for. So we haven't got that to lock into. And I think it's incumbent on all of us, now more than ever, to be advocating hard for that national approach, that national strategy. We know that a significant amount of work went into drafting the Health Disparities White Paper led by the Office for Health Improvement Disparities. And, that might well be a good starting point for a new government. but it will need a cross-party, cross-departmental mechanism to develop and to deliver it. When preparing for this session, I was interested to discover that of the 7 NHS England OHID regions, it's only London that has a regional health inequality strategy. And it's the Mayor of London has statutory duties, we know, to produce that strategy through the Greater London Act 2007. That said, and more so after hearing our previous speakers, I'm not yet to be convinced that using limited regional resources to develop a regional Midlands health inequality strategy for such a large, diverse footprint would actually add value at this time. So 9 months into my post, my approach has been about building strong relationships with our local authority directors of public health, our system leaders, to develop a delivery plan that seeks to support local work. It's not yet perfected, but it does provide a framework for further co-production and a narrative on what I think the regional capacity and capability can contribute. So putting the challenges to one side, I just want to talk quickly to 4 areas where I think the regional teams could focus more effort to impact on health inequalities at regional level. And you'll see some themes clearly emerging in this. So the first is to focus on the data, the intelligence and the narrative. In order to be accountable, we need to highlight and communicate health inequality to our communities. And as Justin's already mentioned, with a deeper understanding of what we mean by our communities. We need to do much better with routinely collected information and data sets. Either fields are incomplete or they're just not specific enough to inform hyperlocal action. And we've seen that in the work that we're doing across the West Mids on infant mortality, as colleagues have already pointed out, and most recently in the measles outbreaks. And just in terms of the quality of data to target intervention, clearly much more work needs to be done. In the Midlands, through the quarterly review meetings of our 11 integrated care systems, I am challenging underperformance in terms of incomplete data and identifying areas for improvement. And we've established networks to share learning between our systems and with our local authority lead analyst networks. However, as colleagues have alluded to, there's further opportunity in how at regional level we can share the best practice, some of the practice we've heard already today, on translating data into narratives that are meaningful and accessible for our communities to hold us to account, especially where they're being underserved and outcomes are worse. The second point is about supporting and enabling community engagement to hear that citizen voice and co-produce to improve services that seek to improve health and prevent ill health. And that cannot be short-term and acute focused. We've got to do this in a way that's sustainable and I think developed through our integrated care partnerships, working collaboratively between voluntary community sector, NHS and local government. And in so many of our regional priorities and programmes that we're looking at with our alliances across the East and West Midlands, we keep coming back to the need for robust community engagement and co-production. So at regional level, I'm exploring frameworks to support this approach, particularly with regards to cultural competence, embedding this through programmes like the work that we're developing on reducing infant mortality. I'm also collecting areas of best practice. So again, fantastic to have already heard so much good work going on across the patch so that I can signpost others to that best practice and hopefully amplify it. And regional directors of public health now sitting in the Department of Health and Social Care can provide a useful bridge between local best practice to inform national policy making and test and challenge to ensure local experience is represented wherever possible. And what I need in my bag are those examples that I can just put to the table whenever the opportunity arises. Third on my list is to maximise the opportunity of our combined authorities and looking at wider determinant factors over a larger footprint. So myself and Justin sit on a health inequality advisory board to ensure the West Mids combined authorities contributing in ways that are informed by local need, but that remain within the remit of the authority. Our mayors have hands-on levers in rooms that we might not really routinely get into. So it's really important that we invest in that relationship, provide them with the narrative they need to advocate for their population. And then finally, my last point is about using the regional perspective and the role of the regional director of public health strategically to challenge variation in activity and outcomes. I often refer to the regional added value as almost being in the helicopter and being able to spot variation in activity and outcomes across the region and convening our local leaders to explore it. Some of the variation will be down to context and absolutely justifiable, understandable. However, some of it will be harder to justify and deserves further exploration and action. So working with our 23 directors of public health in the Midlands, the 11 integrated care systems and 2 combined authorities means that my team are in a privileged position to use the helicopter perspective to constructively challenge as well as highlight best practice. And I'm working in partnership with our directors of public health to look at how we formalise that approach, calling it supportive assurance. So I'll end there and thank you very much.
Fantastic. Thank you, Mike, for bringing that different perspective on the role of the regional directors. And also interesting you talk about data, which I can see with the questions, that there are questions around data and around sustainability. So I think there is something there that I'm sure audiences will be interested in. So thank you very much. Really interesting points and different ways that and approaches that people are taking to tackling health inequalities. At this point, we've got enough time, quite a lot of time actually. So thank you for sticking to your time for questions. So the first question is from Anna, who asks, how can we get... Apologies. Sorry, Stephen. We've got one more presentation. Apologies about that. The last speaker, before we rush to questions, is Stephen. Apologies. You're welcome, Stephen.
Thank you. Right, I'll just share my screen. Right, so thank you to all of you for your presentations. I think although we've had presentations from around the country, I think there's been a Midlands and a Birmingham focus, and I'm going to continue with that. So I'm Stephen Raybould. I'm Programmes Director for BVSC, which is the voluntary sector infrastructure organisation in Birmingham. Critically, we work with the voluntary community, faith and social enterprise sector. So we're very much interested in faith-based social action, which I think is really important within a Birmingham context, as faith is a sort of an increasing part of how people experience their identity. I won't go over the details of Birmingham and Solihull, but as you can imagine, there is a lot of inward investment into Birmingham and Solihull, but there are very significant pockets of poverty in both places. I'm really going to talk about voluntary sector provision in the context of the wider societal structures, essentially suggesting that the transformation means that we need both institutional integration, but also that must act as a catalyst for wider social change rather than being an end in itself. And really that's how we get at addressing the health inequalities that are present. So I'm just going to go back. So I'm going to talk essentially about VCSE, but really I'm talking more generally about the role of VCSE infrastructure in prompting social change and addressing health inequalities. What you've got there are 4 exemplars of our activity, and I would refer to those as behaviour change, resourcing, data intelligence, and access to services. Now, we do lots of other things as integration, building partnerships, advocacy, securing non-Birmingham pound, system change work and campaigning. But I think those are really the core components and really how we as an infrastructure organisation support addressing health inequalities. Critical to all of this is really understanding what good looks like in relation to the civic space. And then in the context of health inequalities, this means making a contribution towards building a salutogenic environment. And really, when we are working with the voluntary sector across all of our activity, that's what we are trying to achieve. We know that we can't do that by ourselves. We know that we can't do that just with the voluntary sector, but we're looking at making a contribution. So as an organisation, we have a health and social care unit. This provides some detail around the activity that we undertake. So we provide a portal which helps people with wellbeing services. We look at community engagement. We work with public health justice teams. We've done digital co-production around digital inclusion and personalised care. We've looked at a compassionate city charter, which is around palliative and bereavement care. And critically, we work in partnership with the City Council, with the ICS and with the ICB and the National Institute for Health Research. As a way of holding this all together and holding it together as a sector, we have embedding the VCSE sector into the ICS programme. Part of the work of that has been contributing to the development of the 10-year strategy, which just in reference. But the focus really is about mobilising the whole sector to tackle social challenges. So the VCSE Leadership Alliance is an elected body that holds the reins for looking at voluntary sector integration. The aim really is to open up as many pathways as possible between the sector and the wider system. We are very focused on supporting broad-based prevention activity, and we engage as broadly as possible through the existing infrastructure channels. We try and adopt as broad a model as possible, and the critical thing that we are looking for is maximum engagement from the sector, and that supports addressing health inequalities, because unlike the institutional structures that we have around both the city councils or the health service, our organisations are structured around communities. So through engagement with those organisations, we can get into the detail of communities and into the detail of addressing health inequalities. So the voluntary sector provides lots of different things. I think critically for us, the battle's been won around it providing delivery capacity. So it's really important for us to get across that the voluntary sector is about delivery, not just engagement. And I think that there was a conversation with the health system at the start of all of this that we had to work quite hard at. We're close to communities. VCSE structures have often been developed out of communities rather than have been helicoptered in. We offer shorter command lines. We're not a closed shop. We can be much more responsive and innovate at pace. We're not beholden to an assessment line and are focused on overall outcomes rather than crisis intervention. I think that's really important. And we can be the eyes and ears of the system on the ground. We can feed information quickly up into the system. And I think all of that's really important, because health inequalities, although they remain quite constant, are driven by different factors that are going on with the communities, and that the system being alive to that is really critical. So part of that activity has been the engagement work that we've done around the 10-year strategy. In a moment, I'll come to the you said we did slide around the 10-year strategy, which Justin worked really hard on it, and it's been brilliant to have the support of a system with a leader in it like Justin, who has been critical in driving the right approach. It was built out of the work that was done previously, so previous strategies, but there was a model there where we engaged with the sector and this sector engaged with the communities. So they're both place-based and thematic. And because the sector's structured around communities, we really got into an in-depth conversation about what should be there and what needed to be reflected more strongly. I think one of the key change, and I'll highlight this at the moment, was that diversity around identity was reflected adequately in the strategy, but some of the social exclusion, especially within Solihull, which is actually in one of our more affluent areas, was felt around mental health, and that there was lots of emphasis on changing that within the report so it had a greater place, and that was picked up. And actually now we're in a position in Birmingham where the mental health provider collaborative is the most mature out of our provider collaboratives. So in terms of, you said we did, there's a list there on the slide about what changed as a result of the conversation with communities. And it was really interesting what came back. A lot of it was about making sure things are measured and that the difference is actually achieved. So I think broadly the communities felt that there were the right focuses with a greater emphasis on mental health, but they wanted metrics added. So there's a list of things there where the team developing the strategy have gone back and said, look, this is how we're going to examine it, and this is how we're going to show communities that we're making progress in those areas. There's a couple of observations we'd make around working with the system from a VCSE perspective, and these are both about the role of the voluntary sector, but also about the wider shifts we need to make. It's often touted around that 80% of the health outcomes are in the wider determinants of health and 20% are in healthcare, but still the system's very heavily focused on delivering healthcare. The voluntary sector is in a really good place. We're often at a pre-assessment place with people who are embedded in communities, and we think that needs to be greater concentration in that space. Voluntary sector organisations are actually really good at focusing on outcome measures. It's a real surprise that when you come into the system, you quite often faced with larger organisations focusing on outputs, waiting list, response times, appointment numbers, capacity. I think that's a really important contribution the voluntary sector can make, and as much as we can to lever the focus onto wider outcome measures such as life expectancy and healthy life years, which I think the strategy in Birmingham has done. Generally, our experience within the system is that integrated care systems, they're at an early stage of maturity, but they've been much better at focusing on outcomes than previous iterations of the health system, and actually much better at including the voluntary and community sector. So just my final slide then is some further observations around the role of the Voluntary Sector Alliance, which is essentially the strategic body which looks at all of that. I think one of the ways in which we drive this is to make sure there's strong as inclusion as possible in governance. VCSE prevention activity, and particularly prevention, needs to be defined as part of the treatment pathways. One of the concerns that we have is that what we're getting is attached in a loose way to the system and not really deeply embedded. So that's something we want to look at going forward. We certainly need a transfer of income to high leverage system influencing activities that make a difference in terms of outcomes. That does mean some difficult decisions for systems to make, and we need integrated commissioning. So VCSE provision commissioned as part of a broader care process. Finally, I just wanted to come to something that I think is particular to Birmingham, but is a very Birmingham Solihull, but is a very particular commitment that has been made by our system, where they have put up nearly £22 million to look at projects that address health inequalities within Birmingham and Solihull. It's called the Fairer Futures Fund. It has been delegated to place, but lots of the provision is already in the voluntary and community sector. I'd certainly want to applaud this. I know that it's not happened in every system, and it is a really good start. And we're now focusing on getting that embedded in business as usual.
Thank you very much, Stephen. I think that's everyone. Yes, thank you. And thank you for bringing the VCSE and faith sector into the conversation. And at the fund, we've done some work around, collaboration, partnership working between statutory organizations and volunteer sector. And it's good to see some of the observations that you've made, some of the points that have been raised elsewhere and are continuously being talked about. So it'd be good to come back to some of your experiences in terms of what you talked about outcome measures and versus output, how you navigate those conversations and get everyone on board. So thank you very much. So now going on to our questions. So the first question that lots of people are interested in, we talked about funding, this amazing work that's going on. The question touches on the issue of funding around how do we get rid of short-termism at government level? So many examples of good practice have had their funding withdrawn. It's so frustrating. This is a theme that's cut across in all conversations around short-termism. I think, Mike, you talked about sustainability. So I guess the question is, how do we get rid of that, or how do we work in this space, and how do we navigate those challenges? So if I can start with Justin, would you like to answer first, and then we can have people jump in as well?
Sure, thanks, Lorraine. I mean, I think it is an important question. I think we've got to be realistic about the nature of what national government do and what they can and can't do in political cycles, and that's true also in local government. And I think often when we think about ICSs, we do get a little bit NHS centric. We need to think, remember this is about a system, and the system has lots of different ways of funding. But I think one of the great challenges we have, and Stephen picked it up in his presentation, is how do we unlock the NHS funding streams to make them sustainable funding sources for interventions that we know work, but are provided by particularly community and voluntary sector organisations. Because too often, and we had a particular challenge for us in our own system, where we had an intervention which demonstrated clear evidence of improving maternal outcomes with specific ethnic communities, and it had been funded through non-recurrent grant money, and the money was running out, and people were all turning around going, oh, can someone else find some more non-recurrent grant? And the question then, the challenge was, well, why, if this works and it's part of maternity, why are we not funding it from the maternity block contract? And that has then led to a series of ongoing conversations about the reality of the way the NHS funding works, and how do you disentangle, which is now even harder with provider collaboratives where we have block funding rather than payment by results or tariff-based funding. How do you disentangle that, or how do you integrate into that in a more positive asset-based way the commissioning of these bits of the pathway that sit outside of things provided by hospitals? And I think it's still a journey we're on. But ultimately, that I think is the only sustainable answer to funding, because the reality of local government and national government is political cycles of 4 years. So the answer really, I think, is for ICS systems to truly understand how to make pathway funding full pathway funding, and not just the NHS bit of a pathway. And that has to start with how the NHS money runs, rather than going, well, someone else was funding it before, because in general it wasn't funded by someone else before. It was funded through a non-recurrent grant, normally from Department of Health. So I think that is the wicked problem that Stephen alluded to, and is at the heart of this, and that is the solution we've got to get to, that gives us a much more sustainable set of solutions that will truly address the health inequalities that we need to work together to achieve.
Okay, thank you, Justin. Is there anyone else who had anything else to add? Stephen, would you like to come in?
So I think, and just to build on what Justin said, really we have to fund the pathway and not the problem. That the difficulty, and this is a small p political challenge for the NHS, is that what they've got to look at is, okay, if helping people before they get into crisis helps more people, that's where we need to put the money, but that will create less money for when people get into crisis. That if you're an NHS manager and you are dealing with ambulances piling up outside of your hospital, that is a really serious issue. But there needs to be some leadership bravery and also a process created for transferring that investment. I think we're just not quite there yet in terms of level of maturity, but it needs the different systems to build it.
Yes, Justin, do you want to add anything? Anyone else?
Yeah, if I can just come back and build on Stephen's point, because I think it's one of the things, and he talked about Fairer Futures, which I'm currently system SRO for. And one of the things we worked really hard in building that funding stream was working with both clinicians, commissioners, and providers in the voluntary and community sector of what are the metrics of success? What will tick your box on all sides so that you can show what you're doing is measured and has an outcome that links back to the way you measure success? And then how does that connect with the logic model that understands that if we do X, then Y happens, and Y can be monetized? And that's the real challenge for us in the system, is how do we move the pathway conversations from counting bums on seats, people through hospital beds, out of hospital beds, to actually going back to what I think was at the heart of the long-term plan for the NHS, which was moving to patient experience and patient level outcomes. We know if we can get someone achieving more than 30 minutes of physical activity a week, we will improve their outcomes if they're a type 2 diabetic. If we can get them to 150 minutes, brilliant, but I'd settle for getting them above 30. That requires us to have a clinical pathway for type 2 diabetes that integrates supported physical activity. That means our gyms, our leisure providers, our heritage walk providers need to be aware and diabetes confident to enable those people to participate. But it also means we've got to work, and I think that is I'll use the Royal Public Health we've got to help the NHS side of the system being able to monetize that into this is how that's reducing an unmet need or an unseen demand that's coming down the track that actually we're heading off, and that's going to help you achieve financial balance. The same is true for social care. If we can get you physically active, we can keep you at home independent for longer and defer your need for adult social care. But I think we've got to have a much more sophisticated narrative that fits around this, that says if we're doing these things in the prevention space or in that very early intervention space, as soon as you start to dip down, that is cost effective to the system, because what we're doing is reducing the demand rise. And all of us are looking at what was the Barnett graph of doom. I don't know whose graph of doom it is currently, certainly feels like the Birmingham one, where demand is just increasing as we have an aging population with fewer years lived in healthy life expectancy. And if we cannot reduce that demand, then the public sector will not survive in the way that it is currently. And that's the fundamental thing I think we're wrestling with in this space.
Thank you. I think Emma, you wanted to come in as well.
Yeah, I think there's a real issue in the way that we look at evaluating success in some of these measures. So cost and price are not the same. So I think we need to move away from, the kind of the moral case to a business case for funding health inequalities. And actually, the way that most business cases are constructed is often looking at things like payment by results, but that's a cost, it's not the price. So I think we've got to change the way we think. And I talked about, this isn't about the NHS. The NHS can't act alone in this space. This is about the Sheffield pound, what we do collectively. But also, I'm not asking for 100 pages of evidence about the work I'm doing in North East Sheffield, because guess what? It doesn't exist and it probably never will. So we need to hold our nerve, be courageous, accept that where we are currently in the NHS, if we don't do things differently and make our communities resilient and empower them to take, different decisions about their own health and well-being, we are not going to make those changes. So we need to have an eye on both. We need to kind of do the business as usual, but also think about the transformation space, which is where our health and care partnership exists, where we come together as a partnership to add value, to solve some wicked problems that only we can solve as a system. We don't try and solve organizational problems. So again, I think, where do you put your capability and capacity and thought into how we're going to solve this problem moving forward?
Great, thank you. And it's interesting points that keep coming up, like say, Justin, that NHS is part of a wider system, and as you've reiterated, that system, they're different partners. And I think, Anya, when you did your presentation, you talked about creative thinking. I guess that's also quite fundamental to it, is creative thinking and also changing the narratives. As we know, the narratives are really powerful in shaping how we approach and tackle some of the challenges. So thank you very much for that. And I guess probably coming back to you, Emma, there's a question linked to funding, are always conversations around power. So the question is, what are your 3 top tips for where to begin with true devolved power sharing, specifically thinking about traditional healthcare organizations and their engagement? Any thoughts on that?
Just in terms of the partnership, it's real. So from day one, when I started, and I hate using the governance word, it's a means to an ends, but actually we agreed the governance as a system about how we'd start to deploy our resources in Sheffield. So that was co-produced. We've only got 5 priorities in Sheffield. We haven't got 20. Every time you go into a system, you pick up 100. But what's static is the people that live there, usually in your workforce. What we do is keep changing the goalposts and wonder why we never achieve anything. So we've got 5 priorities, one of which is the Northeast work. And so all providers, all the local authority, the Health and Wellbeing Board, elected member, everybody has agreed that we have the governance of the partnership, how we do business, what our 5 priorities are, and how we then start to resource them. And as I say, we are in a financially challenged situation. I'm sure other ICSs are, but I've still been able to make that case for retaining the health inequalities funding and targeting it to one small part of Sheffield. Because if you start to dilute that resource, again, we're never going to be able to make any impact and measure it. So by having New Local involved alongside us as our evaluation partner, this is, we're not, and it comes back to the thing you say, we're not going to have pages of evidence. We've got to hold our nerve and be courageous in this space and work with other partners, other charities, the VCSE sector, etc., who also bring lots of money. And it's not just about NHS money. It's about building the capability and capacity in our communities to lever in different sources of funding. So it's not just statutory funding that is the answer to this either. So that, for me, that it's getting shared vision, joint accountability, shared accountability about how we use our resource in Sheffield, political binding support from our local authority, and really working together with our communities and giving them the voice, basically, not dictating what we need from them. They almost dictate what they need from us, and that's the way it needs to be.
Thank you. And also thinking about power, just thinking that power at different power relations at different levels, because you're thinking of power relations between statutory and the voluntary VCSE and faith sector, and also between all the two and communities. So I think it's important to look at those different levels or different strands of power relationships and how to devolve power and work with, because that's part of co-production, is identifying those power relationships and tackling them in those different levels. So thank you for that. The next question is, unless someone else wanted to come in, I was going to ask a question. Someone asked a question. Anya, you talked about CVD. So there's a question from Elizabeth who says, is there a central place for things like the translated information around hypertension? We're doing a large-scale CVD project aiming to get 10,000 checks done, and it would be great to access, as this is one of our aims. Seems like we are reinventing the wheel. I think it's an important question around resources, and I think Mike talked about sharing best practice. So would you like to come in and answer that question?
Yep, absolutely. So we have a website which we also built on. So there is the website on the slides that I presented, which I understand is going to be shared. It's called the bsolhealthyhearts.nhs.uk/blood pressure. So it was developed, I think, in partnership, or when we started the HIP project, and the East of Birmingham was already doing something, and they had the translated languages, because like Justin said, we're a global majority city, so we have so many languages. So for us in Fletcher, what we did was to look at the ones that are mostly spoken by the African and Caribbean community. So my suggestion would be, the website is there for you to, the information is there for you to copy, use, whatever you need to. But the first thing I think you need to also do is to understand with your communities what are the most spoken languages within your area, because that is what you need to focus on. Because if you then use languages that are not spoken in your area, it wouldn't make sense. So we are very, very keen that we co-produce this with our community. So the first thing is understand the languages that are spoken in your area, and then by all means, go for it. Use our resources. We've got French, we've got Arabic, we've got Tigrinya, we've got Somalian, we've got Bengali, we've got quite a few of the Asian languages that we speak there. So feel free to share with us. But I would say start with understanding your community, your demographics, and the languages that they speak.
Thank you, Anya. I know there's lots to say about this. Just looking at the time and thinking maybe put in a couple of questions. I think the next one is for the VCSE sector. There's a question around recognizing that the point that ICSs aren't always the best place to tackle health inequalities. How can the VCSE or VCSE and faith sector ensure that we're brought into these conversations at all stages of policy and delivery? I know, Stephen, you did the observations, you touched a little on this. Would you like to come in?
So one of the things that I would say this, and I would say this to VCSE College, is the importance of collectivizing and organizing yourself into a shape where the system can talk to you. I think one of the things that's a real struggle is that you look at the system and how well resourced it is comparatively, and you think it should be able to get to you. It can't. It really struggles to do that kind of thing. So you need to create entry routes and forums in which you can have conversations with your local system. You also, I think those conversations need to be considered as part of a process rather than a one-off model. And I think that's really important. So it's about creating ongoing relationships, and it's also about creating visibility. So it's getting your voluntary sector leaders, your community members into those ongoing conversations with the system. So making you business as usual.
Fantastic, thank you. And the last questions really has been an interesting discussion. Fortunately, the last question is on digital exclusion. So what role do you think there is for communities to help us address digital inequalities and digital exclusion, which we know are barriers to accessing health services and therefore can compound health inequalities? I think a very, very important question in these days of AI and technology. Justin, would you like to come in?
Sure, thanks. I mean, I think there are several ways to think about this, and often we go to digital because it's the most cost-effective way of reaching a lot of people without thinking about who it doesn't reach, and that's always an important question that we should be having in any of our work across an ICS system: is who's missing from the data set, and are they missing because we don't count them? For example, on disability, we don't have a good way of extracting data on disabled people. So we kind of almost ignore that they exist when we think about inequalities, yet we're quite good at measuring ethnicity. So we've got there. Is it because the digital platform itself actually isn't accessible? One of the big learnings we've had in the work that Oni referred to and over COVID is actually when we've translated resources, the screen readers don't work. So we've had to really think about what do we do, as well as for some communities who've said to us, well, actually, Somali community is a good example of this, where they've said when we don't really, and we have a written version of our language, but most of our community don't read it. They speak it. And actually, if you want to connect with us, you need to do audio files and do it in a kind of, or videos, but actually written documents, even if they're translated, aren't going to land. So I think there's an aspect of thinking about that. And then I think the other aspect we need to think about is digital, is really thinking about, is it working? We have a digital smoking cessation app, for example, called Quit with Bella. Bella's quite a perky white woman. And we've really intentionally looked at who's using the app. Is it engaging men? Is it engaging ethnic women? Is it engaging the people we need to? And then work with the provider who are using quite advanced behavioral science behind it to go, how are you adapting this to make it culturally competent? And I think one of the things we've really got to start to get better on in our digital offer is thinking about digital inclusion, not just meaning have you got a device and have you got data, because there is a very, very important bit of digital exclusion, which is about poverty of equipment and poverty of data. And we must never forget the poverty of data because it costs to get your broadband. But actually, the other element we need to start thinking about digital inclusion is, are we creating digital tools which are structurally discriminatory in the way that they're being developed and designed, both from the back end because they're driven by predominantly white affluent data sets where people are just not being counted, so they're not driving the algorithm, or because of the way they present and the way they're applying behavioral science to a particular paradigm of lived experience. So I think there's a really big pot to unpack, but I'm conscious I think Mike wants to come in on this as well. It's a really, really important thing. We think in a much more sophisticated way about digital inclusion and digital exclusion.
Thank you. Just 1 minute, Mike.
Yeah, I'll be really quick. I think this provides a really good example of where, again, we can think about the role of regions, almost bridging that local perspective into national policy conversation. We've got to be really smart about whose hands on what lever in what room and use them effectively. And I think a thing that's really come out for me today in this conversation is how we use that local intel, those local insights, and create a pipeline to make sure those people who are having conversations with director generals, policy leads nationally, are flipping the lens on policy making. So it really is rooted in local and the needs of local, and highlights all of the obstacles, issues that Justin's raised from the earliest opportunity, and we form policy sensibly in that way. So use us as bridges.
Fantastic, thank you. So thank you to the panel for bringing different views and pushing the boundaries. I hope for the audiences as well, like pushing the boundaries in terms of thinking differently, using different narratives, thinking about relationships and health widely. So thank you very much for your insights, and I hope the audience enjoyed it as much as we have. So for the audience, if you haven't done so already, please do visit the activity feed to introduce yourself and start networking with other attendees. Also, we look forward to seeing you here tomorrow at 10 for the session where we'll be discussing health inequalities and population health academies, looking at new approaches to building capacity and capability within ICSs. And we hope you have a good afternoon. Thank you very much for everyone for attending.